Tantor Audio presents Reinventing American Healthcare. How the Affordable Care Act will improve our terribly complex, blatantly unjust, outrageously expensive, grossly inefficient, error-prone system. By Ezekiel J. Emanuel. Narrated by William Dufris. Introduction. Aaron's disease. Aaron is unlucky. Truly American, Aaron says that despite her hardships, she is the luckiest woman on the face of the earth, that she might have been given a bad break, but she has an awful lot to live for. Aaron, who comes from a large East Coast Irish family, arrived in Aspen, Colorado one winter to visit her brother, who was taking some time off between college and graduate school. She fell in love with the place and remained for the next 23 years. She also fell in love with Justin, an accomplished mountaineer whom she married in 1999. Justin and Aaron made a good life together. He worked each winter as a ski patroller on Aspen Mountain. She started a marketing company and was self-employed. In 2000, Aaron gave birth to their first daughter. 3 years later, they had their second. Aaron and Justin had the usual struggles of a young couple raising 2 children, finding affordable housing, expanding the hours in the day to accommodate the children, friends, work, themselves, keeping in touch with family out east. But they also felt blessed. They lived healthy, active lives amid the beautiful scenery of Aspen. They hiked and biked and skied together as a family, and they formed close friendships. They rarely needed to worry about their health or engage the healthcare system. Everyone ate a healthy diet. They were physically active. Neither Aaron nor Justin smoked. Neither had any chronic condition nor took medications regularly. The girls did not have allergies, asthma, or any other childhood health problems. Besides 2 C-sections for the girls, no one had been admitted to the hospital. Then tragedy struck. A few days before Christmas in 2008, Aaron and Justin had an amazing morning skiing together. 2 feet of fresh powder had fallen the previous night. Skiing conditions could not have been better. After lunch, Aaron left to meet their children, and Justin went back out to ski, alone this time, heading for his favorite, almost secret spot on the backside of Aspen Mountain. It was an area he had skied hundreds of times previously. Despite a promise to be home in a couple of hours, Justin never returned. A nighttime search of the mountain found his frozen body, buried in a freak avalanche 100 yards wide and 3 feet deep. The coroner's report concluded that Justin had died almost instantly of blunt force trauma, a result of hitting a tree and being buried under the snow. With the support of her parents and her Aspen friends, Aaron carried on as a single mother of 2 young daughters. Over the next few years, she recovered from Justin's death. She began living her life again. Her daughters were recovering too. Her marketing business was thriving. They were still a healthy family. In 2013, tragedy struck again. In March, Aaron and the girls went to Mexico with friends for a spring vacation. A few of the people on the trip got Montezuma's revenge that lasted for a day or 2. Aaron did not experience any problems. But after being home 2 weeks, she began to have severe abdominal cramping, followed by bloody diarrhea. Because of the blood, Aaron went to her family physician. Once she heard Aaron had been in Mexico, the physician thought it might be a bacterial infection. She ordered some stool cultures. Aaron tested positive for a Campylobacter intestinal infection. She was treated with some antibiotics. The cramps subsided and the diarrhea resolved. After she finished the treatment, Aaron did not feel great, but she seemed to be recovering. About 2 weeks later, however, the cramps returned. Aaron's physician thought the medicine may not have gotten all the infection, or that she may have developed a secondary infection. So they tried a combination of 2 additional antibiotics that would kill 90% of anything that was there. It didn't work. Instead, Aaron was getting worse. And then she felt a mass-like something in the lower part of her abdomen. It was clear to Aaron that something was wrong. On May 9, she went to the emergency room of the small Aspen Valley Hospital. The healthcare team was still focused on the possibility of an infection. They ordered a CT scan. While Erin was waiting for the CT results, a nurse asked her whether there was anything she needed. Not having had anything to eat or drink all day, Erin asked for some water. After Erin had taken just 2 sips of the water, the nurse rushed back into the room and took the water away. "The doctor is coming to see you," she said. Clearly something was wrong. Seriously wrong. The ER physician said that Erin had a large section of telescoping colon. Technically, that is an intussusception, in which one part of the colon swallows or overrides the other. Though regularly seen in younger children, this is very rare in adults. In the report, the radiologist reading the CT wondered whether some fat bulge might be causing this telescoping. The ER physician said the intussusception could cause serious problems, strangulation of the colon and perforation, and that it had to be dealt with by emergency surgery in the next 20 minutes. Trying to keep her head, Erin asked whether the surgery could be done laparoscopically. Could the doctors wait to get a second opinion? Maybe send her to Denver for such a serious operation. But no other surgeon was available for a second opinion. Indeed, the surgeon on call was not an Aspen Hospital physician, but rather a visiting surgeon from Maryland. The surgeon thought it was an emergency because they could not see what was wrong and a large stretch of colon was involved. He told Erin he felt it was imperative that he get in and operate immediately to investigate what was causing this telescoping and deal with the problem, hopefully before any serious damage was done to the colon tissue. Erin, feeling that the situation was quite out of her control, had to pretty much release myself to the medical team and trust that they were going to take good care of me. She went into surgery. The next thing she remembers is groggily waking up in the recovery room. I was later told that the surgeon had explained what he had found, but I don't remember any of that, she said. I overheard someone saying something about cancer. I pulled over the surgical nurse. I looked at him and asked him, "Are they saying I have cancer?" Poor guy. He was the one who had to tell me. Erin was shocked. Neither the emergency room physician nor the surgeon had focused on cancer as a possibility. While dodging a perforation, Erin had suddenly become a cancer patient. The surgeon thought I would need 6 months of chemo and suggested that I should prepare myself and my children. I had no idea where I would find the strength and what it was going to do to my children, who had already been through so much loss at just 12 and 9 years old. I was trying to process all this as a single mom. Fortunately, Erin's support structure kicked into place again. Her mom was on a plane from New Jersey 24 hours later. Her friends took care of the children and lined up meals. In these resort communities, where people live far from their relatives, they quickly find other people who become their circle of friends, their extended family, Erin observed. It is a very supportive community, and I have a lot of close friends. I couldn't keep them out of my hospital room. I am not alone in Aspen. Nevertheless, Erin says, I never felt so all alone in all my life, including after my husband died. It was a really... She trails off for a long time, as though the moment is returning to her, then mumbles, a very tough time. A few days later, the pathology report came back. A 6.5 centimeter invasive adenocarcinoma of the right colon that is well to moderately differentiated. All margins uninvolved with tumor. 15 lymph nodes are negative for tumor. It meant that Erin had a very large colon cancer that did not look aggressive and did not appear to have spread. The surgeon, however, did not believe the report because the lymph nodes he removed were too big and hard. He thought the cancer must have metastasized, so Aspen Valley Hospital sent the tumor and slides to the Mayo Clinic in Minnesota for another reading that confirmed the first report. No spread. Erin followed up with a local Aspen oncologist whose view was positive that although her tumor was big and he could not say the surgery cured her, his review of all the recent studies indicated that chemotherapy was unnecessary and that having the chemo would improve her survival prospects no more than 1% to 2%. In his view, Erin would not need 6 months of debilitating chemotherapy or any other treatment. For Erin, it had been a wild ride. On Thursday, I had diarrhea. On Friday, I had cancer and needed 6 months of chemotherapy, and on Monday, I was cured, she said. I had a lot to process and take in. It was really unbelievable that I was being told to forget I had cancer and get on with my life. But Erin was not done yet. Given that she was only 48 years old, the oncologist wanted to get a genetic test to see whether she had Lynch syndrome, an inherited disease characterized by colon and uterine cancers that present at a very young age. The oncologist said that the test would cost over $4,000, but given her situation, Erin's insurance company would probably cover the cost. Although cancer didn't run in her family, relatives had had heart disease and heart attacks, but no one had ever had cancer of any kind. The oncologist recommended it, so Erin agreed. This was the first time anyone had ever mentioned the cost of anything. It was not the first bill Erin had seen. The bill for the initial stool culture test had come back in the weeks between the diarrhea and the visit to the Aspen emergency room. It was a whopping $1,200. Erin assumed her insurance would cover it. Because she was self-employed, Erin had bought her own health insurance. In 2012, the monthly premium was about $800 for her and the two girls. She had chosen a high deductible plan, so every year she put $5,000 into a health savings account, HSA, to cover the deductible. If she did not spend it all, the remaining money would roll over to the next year. If she spent it all, the health insurance kicked in to cover the remaining bills. For the first few years, Erin was able to roll over some money, but recently, because of higher health care costs, she knew she would be spending the full $5,000. Many of her friends were urging that Erin get a second opinion from a colon cancer expert. One of the nice things about living in Aspen is that everyone knows someone, she said. A friend who grew up in the Houston area told me that her father has his name on a building at MD Anderson Cancer Center in Houston and could help open some doors there. She helped me get in contact with them. MD Anderson began the process to have Erin come in for a second opinion, and she began filling out the paperwork. 3 weeks later, however, as Erin was about to purchase her plane ticket to Houston, MD Anderson called back. They told her that they contacted Erin's insurance company and that they were out of network. This meant that to see an oncologist at MD Anderson, Erin would have to pay, in addition to her $5,000 deductible for in-network services, another $10,300 deductible for out-of-network services. The clerks at MD Anderson would be happy to see her, but she had to come to the appointment with a $10,300 check. For any services over that, her insurance would cover 70% of the cost, and she would be responsible for the remainder. If this had been life and death, and I thought MD Anderson was going to have the magic bullet for me, I would have found a way to get the money, she said. But given the circumstance that I wasn't dying, I decided to see if there was a highly regarded colon cancer expert in-network. I spent a lot of time on the phone with my health insurance company to see if they could help me find a Colorado colon cancer expert. The representatives I spoke with were based in Michigan and didn't have a lot of information about my network in Colorado. After several fruitless conversations with multiple representatives from the insurance company, I was directed to a website. The best I could come up with was a list of Colorado oncologists in-network with no hospital affiliation listed or designation of their specific cancer specialty. Basically, the insurance company told me to call the doctors myself and ask if they were colon cancer experts. Fortunately, Erin found that the colon cancer experts at the University of Colorado Cancer Center in Denver were considered in-network. It wouldn't cost her anything more to see them. They were very accommodating and very helpful. They reviewed my case with their tumor board and spent a good amount of time reviewing my pathology, my history, and my surgical reports. I was really pleased with the care and service there. Ultimately, the University of Colorado colon cancer expert concurred with Erin's Aspen oncologist. We would not recommend adjuvant therapy in this setting. We do recommend colonoscopy at 3 months out from surgery and CT imaging at 1 year. But Erin was still not done. Even though the Lynch syndrome test did not show evidence of an inherited cancer, the University of Colorado oncologists recommended Erin be seen at the hereditary cancer clinic for further evaluation of other potential genetic changes. About a month after her surgery, Erin was feeling much better. Although her energy was not completely back to normal, she was able to resume biking, hiking, and a full work schedule. And she had started to recover emotionally as well. Of course, the episode left her and her daughters with a host of unanswered questions. Was she cured? How much should they worry about a recurrence? Should she change her diet or exercise or do anything differently? But Erin was grateful, too. Grateful that she had good care. Grateful that her cancer was not as serious as it might have been. Grateful for her life. "I am taking every day as a gift," she said. "I am not focusing on what could happen in a year or 5 years. No one knows better than me that we don't know what might happen tomorrow. Overall, I feel really good and lucky." Then the bills began pouring in. The bill for the hospital stay for the CT and surgery, with the 6 days in post-surgical recovery, was a monster $71,397.91. The largest portion, nearly $30,000, was for the operating room services. Anesthesia added another $7,155, and sterile surgical supplies in the operating room added $8,655. 6 days in a hospital room came to $9,031. The CT scan was $3,829, and the pathology for determining the cancer was $2,368. The surgeon's fee came separately at $4,174. The insurance company's negotiated rates with the hospital reduced that bill by about 8%, bringing it down to $66,382.11. And there were other bills. The physician office visit and blood tests for the initial evaluation of the diarrhea came to $858. Another $287 was owed for the physician visit to change antibiotics after the cramping came back. Various antibiotics and other drugs added $96.71. For all the work they did reviewing the CT scans, medical records, and pathology, the consultation at the University of Colorado seemed reasonable, maybe even a bargain, at $480.42. Altogether, there was just about $73,000 in bills after the insurance company's savings. The total was nearly 140% of the median family income in the United States. Then, Erin's insurance company initially denied the bill for the genetic test for Lynch syndrome. Erin appealed, getting letters from her primary care physician, the University of Colorado Cancer Center physician, and the Aspen oncologist who ordered it. The company then reversed course and eventually approved the charge. The follow-up colonoscopy was still to come, as was its bill. Erin had not paid all of her deductible, and she was responsible for $2,304 for the initial lab work surrounding the bacterial infection, stool samples, and blood tests. Then there was $538.50 for the hospital stay, and an additional $1,505.87 for the surgeon. Paying just under $5,000 for a life-saving surgery and cancer diagnosis seemed reasonable to Erin. Erin's health insurance came up for a renewal in the early fall, but this time she had a pre-existing condition, colon cancer, and a pre-existing set of bills, about $73,000 even without any chemotherapy. Erin had heard stories of people with newly diagnosed cancer being denied coverage or charged exorbitant premiums when their insurance came up for renewal. Erin felt that because she had been paying health insurance premiums for many years, using very little most years because everyone in the family had been relatively healthy, she had been saving up for a time like this, when she would need the insurance coverage. But to the insurance company, she was a person who had had colon cancer and was at risk for really big bills if it came back. October 2013 was her renewal date. Through the late summer, she waited nervously for the insurance company's decision, which came in September. The good news was that the insurance company did not cancel her policy despite her pre-existing condition. The bad news? They jacked up her premium 24%. Luckily, this was just as the Affordable Care Act began its coverage, when on October 1, 2013, the new online insurance exchanges opened for enrollment. People like Erin, who do not get their health insurance through their employer, can go online, view and compare different insurance policies, and choose the one they like best. In the exchanges, insurance companies are prohibited from considering pre-existing conditions like colon cancer and setting their premiums. So people like Erin can go online and obtain insurance without pre-existing condition exclusions and without cancer pre-existing condition affecting the rates charged. "I really didn't think that Obamacare applied to me," she said. "I thought it was health insurance for poor people who couldn't afford to purchase a policy, It never occurred to me that overnight I could become one of those people. I would read articles in the newspapers when the bill was passed, and frankly, it all seemed very complicated and I could not follow it. And since I just didn't think it was relevant to my life, I would turn the page to another article. Having an unexpected and unfortunate diagnosis and struggling with the current healthcare system is not limited to self-employed, relatively well-off people living in Aspen, Colorado. Wayne is a hairstylist in Philadelphia. He is a 40-year-old divorced father of one child. For the last decade or so, he has been going without health insurance and avoiding the doctor almost at all cost. The salon doesn't provide any health insurance, really any benefits at all, he said. I haven't been to the dentist in, I don't know the last time. I know I have a cavity, but I can't afford to get it taken care of. I just floss and brush my teeth really carefully twice a day. A couple of years ago, Wayne could not avoid the healthcare system. He smashed his elbow. Hoping it was just badly bruised, he carried on. After it became clear the injury was getting worse, not better, he went to the emergency room where, after an x-ray confirmed a broken bone, they put him in a cast and referred him to an orthopedic surgeon. The surgeon immediately took the cast off. It was going to heal improperly and permanently restrict my range of motion, Wayne said. He hasn't been back to any doctor since. In July of 2013, Wayne did not know anything about Obamacare and what it could do for him. When told there would be a health insurance exchange offering different health insurance plans and that he might be able to get a subsidy to buy coverage, Wayne became excited. Do you think I could get coverage for $150 per month? $150 per month is probably the limit of what I can afford. After a long pause, during which he seemed to be pondering the possibility of health insurance, he continued, Let's hope I can get insurance for $150 per month. Baltazar is the quintessential immigrant. He came to Los Angeles from Mexico when he was 14 years old. He had few job prospects, few dollars in his pocket, and few English words in his vocabulary. He went to work as a gardener. In his early 20s, Baltazar took the risk of starting his own gardening company. I started by myself 6 or 7 years ago. Now I employ a crew of 8 guys who work for me. I have 4 guys working for me, as well as my little brother, my medium brother, and my cousin. It is better now. As Baltazar says, no one makes a lot. Working 8 hours a day, every day, his workers make only about $17,000 per year. After a few years, Baltazar looked into buying his workers health insurance. We don't make a lot of money to have good health insurance. It is hard, he said. Before Obamacare, all insurance is expensive, like $500 per month for each worker. Over the years, however, his brothers and workers have needed some health care. A few years ago, one worker cut his finger. He went to a general hospital in downtown Los Angeles and received 7 or 8 stitches. Baltazar paid cash for the $1,800 bill. About 5 years ago, his younger brother developed appendicitis and went to the UCLA emergency room. The appendectomy cost $25,000. His brother has been repaying the hospital $400 in cash every month. He only recently sent in the last installment. In July 2013, Baltazar was in Mexico on vacation with his girlfriend. They were driving along a highway when he suddenly felt a pain in his chest. My heart started pumping real hard. Someone was crushing my heart, he said. He drove straight to a Mexican hospital. Fortunately, Baltazar did not suffer a heart attack, but he did have a blocked coronary artery. The pain was just a warning. However, having a blocked coronary artery at age 30 is very serious, suggesting he has high cholesterol and/or high blood pressure. Who knows what else is causing his heart condition? Since I came to this country, I haven't been to the doctor, he said. I haven't had a checkup. I felt healthy. I always worked fine. But I am sick, and now I have to take medicine and I have to see a doctor every 6 months. I now know all my workers have to have health insurance. Throughout the summer and fall of 2013, Baltazar had been seeing commercials on TV for health insurance. He received a mailing and called the number to get more information. But he won't shop on the Internet. The Internet is creepy, he said. You never know if what you see is true or not. So he keeps calling to find out what he can. It is hard for him to understand. His English is not perfect, and he doesn't really understand about high deductibles, managed care, networks. What Baltazar knows is that he and his workers need to have health insurance on January 1, 2014, and that they can get subsidies. I can't pay $500. No, maybe $200 per worker, he says. I'm going to pay half price of the health insurance. And when he sees that a standard insurance plan at the silver level might be as low as $53 per month for a worker in California with the subsidies, he exclaims, "It's going to be fantastic. I have to get everyone health insurance." Across the U.S., there are tens of millions of people like Aaron, Wayne, and Baltazar with their own stories of illness, struggles with health insurance, and bills that dwarf people's annual incomes. Aaron, Wayne, Baltazar, and millions of others remind us that illness and death can strike any of us unpredictably, and that we all will need health care services. We just don't know when. They also remind us that we may not be able to control when we get sick and with what disease, but what happens next, the quality of care, the ability to get the best, how much it will cost, and who will pay, can be controlled. And it can be changed so that it does not oppress us with worries about whether we are getting the right care or will be stuck with endless bill payments or, even worse, the threat of bankruptcy. This is a book about the United States healthcare system. It tries to make sense of how the healthcare system affected Aaron, Wayne, and Baltazar's care and their lives. Its pages contain a complex web of facts, figures, statistics, and acronyms, all presented in a way that, I hope, will allow you to understand how and why our system looks the way it does. It is an attempt to help you make sense of things that Aaron, Wayne, and Baltazar confronted when they needed care. Things like deductibles, in-network and out-of-network charges, and policies, high-deductible health plans, and hospital bills that total more than the average person earns in a year. It is an attempt to explain the problems with the healthcare system that prompted reform, as well as all the changes that have already occurred and will continue to take place as part of the Affordable Care Act. The American healthcare system is complex. Explaining how it works and doesn't work, its problems, attempts to reform it, and how Obamacare will transform it, requires considering an unusual combination of topics. Consequently, this book will be an amalgam of history, health economics, sociology, contemporary politics, policy analysis, and forecasting that defies simple categorization. The book is organized into 3 parts. In Part 1, the current healthcare system, we review the American healthcare system, how we got here, and our system's serious problems. Chapter 1 reviews the history of the American healthcare system to explain how we developed the system we have, with so many specialists, big hospitals, and hundreds of health insurance companies. Chapter 2 reviews the financing of the system, health insurance companies, Medicare and Medicaid, the role of employers, and who pays. Chapter 3 delineates how Americans such as Aaron, Wayne, and Baltazar get care and how that care is paid for. It profiles other actors in health care, from drug and device companies to the government agencies that regulate them. Chapters 2 and 3 present the tremendously complex American healthcare system in a clear and comprehensible manner. Chapter 4 specifies 5 different problems with the American healthcare system, from the well-known problems of access and exorbitant costs to the less discussed problems of lack of information about prices and quality and malpractice. It shows how these are not just problems about the healthcare system. Rather, they infect the rest of society, including education and the national debt. Part 1 makes the case for reform. Given these complexities and problems, Part 2, Healthcare Reform, then explores the efforts to reform the healthcare system, culminating in the Affordable Care Act, ACA. Chapter 5 reviews the 100-year history of failed attempts to reform the American healthcare system, including the many unexpected twists and turns, such as Democrats who killed reform and Republicans who championed it. Chapter 5 summarizes the hard lessons learned from the past failures to pass healthcare reform. Chapter 6 shows how President Obama was able to overcome the 100-year curse on comprehensive healthcare reform. It also reveals the vitally important but totally obscure practice essential to enacting any law, scoring by the Congressional Budget Office, and examines the fate of 3 key provisions of reform, thereby elucidating how politics intersects with policy in unexpected ways that defy simple political science theories. Chapter 7.
Sample complete. Ready to continue?